Well, good afternoon or good morning, depending on your location. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy. And on behalf of Duke-Margolis, I'd like to welcome all of you to today's timely webinar on drug-resistant infections and the immediate and future demand for novel antimicrobials. Before we get started, I want to thank our staff who helped put together this webinar. That includes Nicholas Harrison, Derek Rapista, Cameron Joyce, Luke DeRocher, and Marianne Hamilton Lopez. This webinar is part of our broader ongoing policy research portfolio related to the urgent problem of addressing drug-resistant infections and antimicrobial resistance by focusing on actions to restore and sustain a market for novel antibiotics and bacterial diagnostics, and creating a care delivery system and public health system around that encourages their appropriate use and data support to support improvements in their use. During the webinar today, we'll be starting with a recent conversation pre-recorded with Senator Todd Young on the threat of drug-resistant infections and the outlook in Congress for bipartisan action to address the pipeline of future antimicrobials. After that, I'm very pleased to be joined by a panel of experts from the United States, including our CDC, from academic medicine, the European Commission, and the AMR Action Fund. Our panelists are going to discuss actions that policymakers can take to support the development of novel antimicrobials, since that is a live policy issue right now, as well as actions to improve the impact of these new antimicrobials, including steps like improvements using new technologies for surveillance and antimicrobial stewardship capabilities. Again, we're very glad to have you with us and for participating in this interactive webinar. If you do have questions, we encourage you to submit them through the Zoom Q&A function. It should be on your Zoom login right now. And so let's get right to that keynote discussion with Senator Young. We're glad to be joined today for a conversation with Senator Todd Young of Indiana. Senator Young serves on the Senate Committee on Finance, Foreign Relations, Commerce, Science and Transportation, and Small Business and Entrepreneurship. Senator Young is a fifth-generation Hoosier. He's a graduate of the United States Naval Academy and a former U.S. Marine captain. While serving in the Marines and working as a business consultant, he also earned an MBA and a law degree, so a whole career of public service, private sector entrepreneurship, and now leading in the U.S. Senate. He was elected to the House representing Indiana's 9th District in 2010, then to the Senate in 2016. And Senator Young, I understand you still reside in Johnson County, Indiana, with your wife and 4 young kids.
That's right, Mark.
Well, good to have you with us for this conversation about antimicrobial resistance. I want to turn to that, but first just ask you, we're coming off the COVID-19 public health emergency now. There have been a lot of efforts to improve coordination and response capabilities across the federal agencies to address some issues that we're seeing there, some interest in emergency preparedness legislation that needs to be reauthorized this year, and that addresses a range of threats beyond just a pandemic. How are you feeling about the steps that Congress has taken and is considering to prepare for these future health threats?
Well, if there's anything that we learned from that global pandemic, from that 2020 timeframe, it's that we have to take every reasonable and responsible measure to address public health crises now. We have to navigate what waivers and flexibilities might be most impactful for patient access and improved outcomes. And Congress has been pretty active on this front. It hasn't always made headlines, but it's incredibly important. We've included provisions in recent appropriations legislation extending waivers to provide that certainty and stability to our healthcare community. And there's been very real progress. I know there's a lot more to do. And with some specific threats, I worry that we are already a step behind.
Hmm. Well, I do want to turn to some of those potential threats. And you mentioned the waivers, the steps to help the federal government work more effectively with state and local officials, with healthcare providers in response. As you know, one of the areas where you played an important role, the Congress did, was in the development of innovative drugs, diagnostics, vaccines to address COVID-19. Those same medical technologies can be really important for addressing other kinds of infectious disease threats, including our main topic for today, drug-resistant infections. As you're seeing this work go forward on designing and funding programs related to health security, what are your thoughts about the development of countermeasures and support for their development against viral bacterial threats, including to resistant bacterial and other organisms?
Well, of course, this is the next public health crisis, by my estimation, and in consultation with so many others, the emergence of bacteria, which are resistant to antibiotic treatment. This is why Senator Bennett and I have partnered together in introducing the PASTEUR Act. The CDC tells us that more than 2.8 million antibiotic-resistant infections occur just in the United States each year, and at least 35,000 Americans die as a result every year. By 2050, drug-resistant infections, which some call superbugs because of their toxicity and the extent to which they can spread very quickly, could kill 10 million people each year around the world. So that's not very far off. That's, about 15 years. This impact would be more than the annual global death toll from cancer. Bacteria will always be evolving in new ways to defeat the drugs that we have at any given moment in time. So the new therapies are always going to be needed to address emerging resistance. We're, in short, in a race with these relentless microorganisms that we can't afford to lose. Despite the fact that antimicrobial resistant infections are on the rise, the global pipeline of the antibiotics we need is frankly insufficient, woefully insufficient. We got far too many drugs that are in development to treat the world's most dangerous pathogens. So we have to ensure that the United States isn't caught flat-footed again to another major global health crisis, in this case, a superbug outbreak. Some threats we can't begin to anticipate as we dream up all the various risks to American lives and welfare. But when it comes to this one, antibiotic-resistant bacteria, there's frankly no excuse not to be unprepared.
Well, you can certainly see it coming, and you obviously are paying a lot of attention to this issue. You've introduced the PASTEUR Act to get at creating this market and support for bringing these new antibiotics forward. And you mentioned how thin the pipeline has been in the absence of support like PASTEUR. So you and Senator Bennett, as you mentioned, have introduced that in the last two Congresses, just reintroduced it in this one. Do you think it's going to be different this time, Senator? Have the circumstances changed enough since PASTEUR was first introduced? I know the bill has evolved a bit since its original introduction as well, but how do you see the odds looking in this Congress?
I'm optimistic. I actually do think that the minds are starting to be focused on this serious threat, especially as we begin to get a bit of distance between the greatest threat of COVID to Americans and move away from that moment in time and look prospectively at not just the continued threat of different strains of COVID, but other sorts of threats. And we're preparing. So specifically what the PASTEUR Act would do, in short, it would reinvigorate the antibiotics pipeline by providing a subscription-based financial incentive for broad public access to the latest, greatest, most innovative, high-priority antibiotics. Pharmaceutical revenue is typically tied to how much of a drug is sold. It's a volume business. PASTEUR contracts would be different. We would instead pay for new antibiotics based on their exceptional value to public health. The approach would solve what is, by my reckoning, the core problem facing antibiotic drug development, which is the pressing need for innovative drugs that don't have high sales potential in the private drug market. You don't know if they're actually going to need to be used or used in a high volume. So as a result, PASTEUR would not only encourage the development of new types of drugs, new antibiotics, but it would also help ensure that patients have access to these drugs once they come on market. It's kind of a Netflix model as opposed to a fire hydrant model where you wait for an emergency and you put out the fire. So it's really crucial that we get this legislation across the line, and a passage, in short, will I hope come later this year. Mark, we're getting a lot of interest from the outside. We have a fair amount of interest on the Hill, and the vehicle I see to get this done is thematically. It's highly consistent with what we're trying to accomplish. It's the reauthorization of PAPA. Yeah. For the uninitiated, the Pandemic and All Hazards Preparedness Act, which will occur later this year, I believe.
That's a great view of the importance of this issue, the opportunity in Congress. That's bipartisan legislation that needs to be reauthorized, as you mentioned, and having these antibiotics available, not for widespread use, but just when they're really needed. So you don't need more infection treatments, things like that. You're obviously on top of this whole issue. Just one last quick question for all of us who are joining this meeting today and are very concerned about this issue. Any further suggestions based on your experience on how to make people more aware of the challenge here and the opportunity to do something about it through PASTEUR?
Well, I do think educating members of Congress continues to be very important. Members of Congress are very busy. Members of their staff are, by extension, often very busy. But to the extent we can empower those who are tuning into this webinar, for example, with the information to go lobby their members of Congress. I know we have a lot of sophisticated people watching. Nothing could be more helpful to us. So. We learned on a tragic scale during the COVID-19 pandemic that these diseases don't care if you're a Democrat or a Republican, and this coming public health crisis is going to be an equal opportunity enemy to the American people if we don't take care of it in advance. So members of Congress are becoming more aware, but to keep seeing reports of drug-resistant infections, most recently the bacterial contaminated eye drops that made some headlines, suggests to me we still have some work to do. I would just encourage those who are watching to reach out to members of Congress and emphasize the human impact of this, and hey, there's a business opportunity as well. Yeah. It really is. You get a lot of great minds out there who are looking to change the world and maybe make a buck in the process. And the world-changing part, which is what we care about, won't happen if we don't change the financial model.
Yeah, Senator, that kind of alignment is critical. And as you say, this is not a partisan issue. Protection for the country, it's important for all of us. Senator, thanks for your time with us today. And thanks especially for your leadership on PASTEUR and so many other issues important for the nation's health security.
It's a privilege to be with you, Doctor. Thank you.
All right, well, to follow up on what Senator Young in that recently recorded keynote discussion called the next public health crisis, we're glad to be joined by a panel of experts this afternoon to discuss the value and the opportunities for novel antimicrobials and the so-called pull incentives we talked about with Senator Young to encourage antimicrobial development and appropriate use to address this growing public health challenge. I'd like to welcome our panelists, Helen Boucher, who's Dean and Professor of Medicine at the Tufts University School of Medicine, Michael Craig, Senior Advisor for Antibiotic Resistance at the U.S. Centers for Disease Control and Prevention, Annika Oyala, who is Deputy Head of Cabinet for Commissioner Stella Kyriakidis, who's responsible for health and food safety at the European Commission, and Henry Skinner, the CEO of the Antimicrobial Resistance Action Fund. All of you, thanks for joining us. So we want to cover in more depth the state of the public health challenge of drug-resistant infections and the state of what to do about it, the individual and population level health impacts of antimicrobials, the state of pull incentives and steps in the United States and around the world to align on policy actions to address it, and the importance of sustaining support for antimicrobial stewardship and appropriate access to contain further AMR spread. I'd like to start by asking you to take a couple of minutes each to highlight or preview any key points or issues that you think are especially important for today's discussion. We just heard from Senator Young, I have to say, a pretty high level of awareness on these urgent public health issues. So I hope you can build on that. Helen, can I turn to you first?
Sure. Thanks, Mark. Good afternoon, everybody. It's a real honor to be with you. I'm a practicing infectious disease physician. I'm having my 30th reunion from medical school this year, so it's longer than I might have thought. And I've been in infectious disease the entire time, taking care of patients, and now have the privilege to serve as the dean of our medical school, the 9th largest school in the country. We teach PhD scientists, people who are going to develop antibiotics, we hope, discover them and develop them, as well as professionals who do public health, and physicians, physician assistants, and other frontline care providers. And the senator did a great job of highlighting some things about AMR infections, but I just want to kind of bring it home in that the problems that we're seeing today in 2023 include bad infections in the hospital that should never happen, but do, and the need to send people home on hospice, which I've sadly had to do, but more and more things happening in our communities. So in our community in the city of Boston, we have persons who inject drugs, and we see them come to the hospital with MRSA infections, a resistant staph infection. Those individuals are 16 times more likely to develop MRSA infections. So this is a problem that confronts every big city in our country every day of the year, and it kills people. It doesn't just cause a lot of harm, but it kills people. Then the senator mentioned the infectious outbreak in eye drops. This Pseudomonas, a bad bug, gram-negative bug, got into over-the-counter artificial tears and spread from California to New York and is not over yet. And in that outbreak so far, as of March, 3 people had died, 8 people had lost their vision, and really importantly, 4 people underwent enucleation, that is removal of the eyeball, one of the most horrific surgeries you can imagine for an infection that they didn't know was there. These little eye drops were in, care providers' pockets in nursing homes, going patient to patient. Nobody knew to wear gloves or protect themselves in any way. This bug is susceptible to only one antibiotic that we have available today. So very scary, very real, and very much with us, affecting me, you, and everyone in our population. So that gets to the antibiotic issue.
Yeah.
I mentioned one antibiotic that it works for. Well, we haven't had a new systemically available antibiotic approved in the United States since November of 2019. And in the last decade, we had 7 antibiotics approved by small companies, all of whom have gone bankrupt. So that gets to the need for PASTEUR. And you heard that beautifully from the senator. The last thing I'll mention is that we need people to do this work. And that comes back to the need for a workforce to discover and develop antibiotics and then to treat patients. And so I just want to add that to the discussion. I know we're here to talk about PASTEUR, Mark, but I wanted to highlight the need for the workforce and say thanks a lot.
No, I appreciate it. I do want to put this in the broader context of how to effectively contain antimicrobial resistance for the future. Obviously, antibiotics that work are a critical part of that, but not the only element. Next, for now, can I turn to Michael?
Thanks, Mark. Great to see you. Thank you again for your leadership on this issue. It was great to hear from the senator as well. I mean, just building on what you and the senator talked about and Helen's comments, I mean, I think that a couple things to underline is that this is not a potential problem. It's a current problem. It's one that we live with on a day-to-day basis. Helen gave some good examples of that. One statistic that hasn't been mentioned currently is the global impact of this, and that this is a burden that we see killing at least 1.27 million people worldwide, and is associated with nearly 5 million deaths. And that's a huge amount of morbidity and mortality related to antimicrobial resistance. That is, to put that in perspective, it's more than HIV or malaria, which we already consider to be global killers and global threats that we face. I think the other thing that is critically important for us to remember is that antimicrobial resistance and effective antibiotics are necessary for all of the medical advancements and the medical infrastructure that we have in place, especially in the United States. So things like cancer chemotherapy and the efficacy and the benefits and the developments and the progress we've seen in folks living longer who are on cancer chemotherapy is predicated on having effective antibiotics to be able to address infections that may arise while they're immune compromised. There are so many different things that we rely upon for surgeries, for complex medical procedures, that this is really one of those issues that literally has the potential to affect every single person on the planet. And the diversity of challenges that we see with it, and the challenges that we see in terms of antibiotics used not only in human medicine, but in agriculture, as well as in the environment, only compound a lot of the challenges that we see. So I think one of the things I want to note and just emphasize is that we do need to address the pipeline. We do need to improve the public health response and the prevention efforts along this. And we need to do it now, because if we don't, this problem is only going to compound itself. It is a crisis, and it is a threat that we face today, and not a hypothetical one that we're going to have to just address in the future. Thanks.
Thank you. And Annika, can I turn to you next?
Thank you very much for inviting me here to bring the European perspective. I think the previous speakers have highlighted already the magnitude of the problem, and maybe just mention some elements from the EU side. I think we are facing similar numbers as was mentioned already to the Senator. We are looking at 35,000 deaths in the EU yearly, and these are increasing, and the cost for the healthcare system is around 1.5 billion annually, and 70% of these infections are related to healthcare associated infections. What we have seen in the EU is a decrease in the consumption of antibiotics, actually around 23%. And this happened especially during the COVID pandemic. But the use of broad spectrum antibiotics has increased. And at the same time, while the consumption has decreased, we see that the AMR has increased. And this is very concerning, especially to the resistance to critically important antibiotics. And it was already mentioned by the previous speakers, we see that the AMR-related health impact is more than from HIV, influenza, and tuberculosis together at the moment. And the deaths, especially from the Klebsiella pneumonia and Acinetobacter, have increased around 50%, which is very worrying. So we are, as mentioned, it's time to really act on this now. And we are taking a lot of action in different fronts in the EU. We have learned a lot from COVID on preparedness, response, and what we have to do. And AMR is considered one of the 3 top health threats we are facing now. And we have just passed new legislation in EU, 26th of April, a new pharmaceutical package. So really focusing more on the human health side. This time we have quite recent legislation on the veterinary side, which is of course very important. And in the One Health perspective, we have to look at veterinary, human, and environment. And this legislation includes, we have discussed the PASTEUR Act, what it has. We have both regulatory and financial incentive to address this market failure, the dry pipeline that has been mentioned, that we do not have new antibiotics. And what we have proposed is to have a transferable exclusivity voucher as a regulatory side, and also on the financial side, we are looking at a procurement mechanism. A little bit was what was mentioned here, the type of subscription models or a market reward system. But I think happy to raise any of these issues in more detail if needed after. Thank you very much.
Yeah, thanks, Annika. A lot of issues to come back to there. Henry, can I turn to you next?
Yeah, thank you, Mark. And I think Helen and Michael Nuka have really identified the growing need, right? The patient need that we have for effective antibiotics to treat these drug-resistant infections, which are only growing. The numbers are daunting, and where we're heading in the next decade or two is just striking. But I want to touch on that, the development of new antibiotics and some of the challenges. And Helen pointed it out, of the small biotechs that have developed the last 7 antibiotics in the last decade, these companies have gone bankrupt. And that has really perpetuated and accentuated the challenge we have. The problem isn't the lack of good science. We have great scientists. We've been incredibly impactful, innovating across healthcare to enormous patient benefit. The problem in this space is that with those bankruptcies, we no longer have investment in developing new antibiotics. And so the pipeline has continued to wither and is far from adequate now. It's too few, doing too few things, and really just a lack of innovation, financing the innovation because of the market failure, the bankruptcies that have come from that. We use antibiotics and we have stewardship and other programs entirely appropriately to try to drive the use of the right antibiotic for the right patient. And the new antibiotics have to be held in reserve so that we use them only when needed in order to limit new resistance formation and these drugs becoming ineffective. But the problem is the value of an antibiotic is not measured by the number of units sold this year. These drugs would be with us and provide benefit for the next 100 years and more. And so we need to really focus on recognizing the societal value that these drugs bring and the formation and really enabling healthcare from chemotherapy to organ transplant to prosthetic joints to frankly simple surgeries, protecting women after cesarean section and the like. It's instrumental in our healthcare. And yet the market failure leads to lack of investment. The lack of investment leads to a pipeline that's too thin. And so we have to have policy changes that fix that. And let me touch on one other thing, and Helen brought it up. We are suffering a brain drain from this field, from the lack of innovation, the lack of financing. Scientists who've been in this field are leaving it or have left it and are not likely to come back. And we're losing a generation of know-how. And if it takes 10 to 12 years to develop a new drug, we can't afford to be back on our heels and restart things and have to learn over again how to advance these things. So we really have enormous urgency to fix this, to address it now in order to bring financing back and move forward a robust pipeline of the drugs that we need.
Thanks very much, Henry. So I do want to come back to those issues related to the workforce and creating the right environment for containing antimicrobial resistance. But I do want to pick up on right now on your points about the incentives for development that have come up a lot here. Paying for a drug like these antimicrobial resistance priority medications on a fee-for-service basis doesn't work. It's kind of the opposite of what's needed, as Anuka pointed out. You're seeing more use of broad-spectrum antibiotics where those probably aren't indicated, which is a good way to build up more resistance. And with the limited uptake of these needed medications, we need a better financing model. So I want to get to that, but first I'd like to spend a couple of minutes more, maybe Mike and Anuka, following up with you all. The whole panel and Senator Young highlighted how resistant infections and the nature of AMR is changing, in some ways worsening in recent years. Can you talk a little bit more about that? How fast are things getting worse? Are there any particular emerging threats that you see as more concerning in terms of harm impact, in terms of where in the world they're having impacts? This is a global problem. I'm not sure which one of you would like to start on that.
I'm happy to start, and a couple things I would note. So, I think what I would say, one is that we had a problem with antimicrobial resistance before the pandemic, and the pandemic only made it worse. It compounded the threat. And what that looked like practically in the United States is that we had actually seen prevention progress for many of our deadliest AR pathogens in the US prior to the pandemic. The pandemic essentially reversed that progress, and we saw an increase of about 15% in those AR infections, especially in hospitals. So the pandemic has made things worse. It challenged us in many ways. The other thing that I would just note that I think is always important to underline with antimicrobial resistance is for us to remember that it's not one thing, right? It's not just a single pathogen. We're talking about a phenomenon that affects a variety of bacteria and fungal threats, and they have the ability to share their resistance with one another. And so that makes it that much harder to address some of these issues. And it makes the ability of these pathogens to elude our best antibiotics that much more significant. So a couple things I would note, there was a mention of the artificial tears outbreak by Helen and by the senator. This is an outbreak that CDC has been working on extensively for the past few months, and we worked with our state health departments to uncover. And it's one that I think is emblematic of some of the challenges that we face, because the contamination of this product appears to have happened overseas, and it appears to have happened in a way where essentially contaminated products filled with drug-resistant pathogens were shipped all across the United States to nursing homes, and they were given to patients unknowingly. And that led to not only patients getting these infections, but what we see and what we're concerned with from the CDC perspective is that pathogen, Pseudomonas, is one that we expect now will spread in those facilities on a secondary basis, meaning people who never got the eye drops will potentially be exposed to this, because the people who did get the eye drops would have gotten colonized with it. It would have gotten contaminated in the environment. It is now something that could potentially become more endemic, those strains of it that we saw, and become a threat that then not only is acute right now, but is something that we have to address for years to come. We see a similar thing happening with the challenges of Candida auris, the very drug-resistant fungus. We've seen that essentially circumnavigate the globe. It was something that we didn't even have a sense of it existing a decade ago. And now it's gone around the world, and we are, a lot of nursing homes, a lot of hospitals are really struggling to fight it. And it has very few treatment options available for it. So this is something where, for some of these very drug-resistant pathogens, we see new ways of spread happening, and we see new problems and new challenges coming up because of the global nature of the resistance and the challenges that we're seeing, where resistance can essentially happen in one part of the world, and it can move. It can move because person-to-person movement. It can move because of a contaminated product, contaminated water, contaminated food. There are a lot of options for these pathogens to spread further.
Annika, anything you'd like to add to that?
Thanks a lot. As you just mentioned, the global nature of the resistance is crucial, and what we are, of course, following closely. And global cooperation is especially important in this respect. And the other element, which I think I mentioned already, was the One Health, that having the overconsumption in animals, environment, as used in plant products and so on, really have to look at this issue as a whole and try to address it in a holistic manner, which we are trying to do. We do see, as mentioned, certain, let's say, key resistant bacteria that we are trying to focus now in our action. We will have new targets that we will try to meet in the EU level, so reducing 20% the consumption, but specifically focusing on the 3 key antibiotic resistant bacteria, trying to reduce the resistance for, as you had mentioned already, the Staphylococcus aureus, also the Escherichia coli, and the Klebsiella pneumonia. And these are the 3 ones that we are now focusing our efforts in the EU side, and long-term facilities, as were mentioned, and hospitals are very, of course, the key areas where we need to look into it. And another element was not to have this broad use, but really try to focus on using the antibiotics of the narrow sense, and using this access group aware classification from the WHO, and try to increase that we better target the type of antibiotics we are using, and introducing more and more prudent use measures, which we have all learned during COVID as well, some of the hygiene ones, but the prudent use also will be part of our pharmaceutical legislation and the new marketing authorization conditions. That this will be very, very important. Thank you.
I appreciate that multidimensional approach that European policymakers are taking, including steps to address prevention of antimicrobial resistance, including in antibiotics used for animal health and growth. And I do want to come back to some of those issues related to workforce and surveillance and stewardship that can also affect prevention. But let me turn next to Helen. So it sounds like, Helen, the value of these antimicrobials to address resistant infections is going up both here in the United States and around the world.
Absolutely. And, you know, I think when we think about the value, Mark, we have to think about the value to the patient, right? The patient that I'm treating, it's priceless, right? And for patients for whom we have no options or we have to make up crazy combinations, which we still do, having something that we know is effective is priceless. But to our society, it's a greater value, right? And that's where antibiotics are different, right? So Michael's comments highlighted this perfectly, because there are the threats we know are here and there are the threats we don't know. That's why we need a pipeline. We need to prepare for both what we know. Pseudomonas, we all are worried about Pseudomonas becoming bad. We didn't know it was going to come in eye drops, but that's a focus. And we need measures to protect our most vulnerable, old people in nursing homes. I mean, that's among the most vulnerable populations we have. And to protect those who we give organs, we spend millions of dollars transplanting organs. The way we support those patients is with antibiotics. So as a societal value, it's extremely high. And this is one of the things I think folks struggle with, is how to measure that, because people are so used to me, my mom, my sister, you know, who has this infection. Thinking about it from a societal perspective is different. And I think that's where the subscription model comes in, because it's a way to preserve antibiotics for their societal benefit and societal value.
Yeah, I mean, the real value, important as it is to those individuals who are infected and otherwise would see, is, as you mentioned, significant impact on their health, if not death. There's real value for all those people who never get the infection in the first place, thanks to the ability to contain the spread through this, as John Rex has called, the fire extinguisher approach. And I guess I'd add to that, while people who need organ transplants have to get the organ transplants and just bear this additional risk of infection, there are a lot of more elective surgeries that can do a lot for quality of life and maybe even length of life, where the risk is bigger. Those become less tenable treatments for improving health as well. So I appreciate your context on the broader extension. I want to come back at the end, if we have a few minutes, to prospects for further action in the United States and Europe this year. But I do want to pick up on the comments that several of you made about the holistic approach here. And frankly, just to be blunt, maybe some concerns out there in the public and elsewhere is that, well, you know, we can put more resources into this new model for supporting the development and availability of priority antimicrobials, but will that be enough? So Henry, maybe I can turn to you for that one. Are there challenges which the pull incentives may not fully address? And what would you suggest? You know, we heard a lot from Anouk about some steps that the European policymakers are considering along with pull incentives, but are there some other steps, short-term actions that policymakers could take, maybe related to development requirements, supporting appropriate use of novel antibiotics, et cetera, that can help create more public confidence that these pull incentives really are going to make a difference?
You know, I think it's a great point, Mark, and certainly this is a broad problem. There's a lot of vectors that come in from animal use, misappropriate prescriptions to people, wrong length of time, wrong antibiotic, et cetera, all of which can be touched. And the PASTEUR Act and other policy changes do address that. They do get into stewardship, so incentivizing hospitals and infectious disease physicians and stewardship programs in rural hospitals and throughout the country to really try to drive the ideal application of antibiotics and maximize the benefit to patients. And so that is part of it. I think there's aspects of surveillance that are important that are captured as well. And that's a really global issue, not only local, but there's a lot better we could do locally in reporting and understanding where the needs are rising so that we can stay ahead of it. So all of that's there. I think that there are some development aspects that are challenges in this space that can be addressed. And these incentives really will focus, and the PASTEUR Act and others are driven toward identifying what are the greatest needs and trying to provide, incentives directed to that greatest need in the US and other markets around the world, and to provide access, right? So I think one of the challenges we faced is even after you've taken the risk and you've shown an antibiotic is good, we do have a problem with getting these to patients that we also need to recognize. And one of the beauties of subscription models is a priori, you're providing access to patients with the new antibiotic and looking to physicians to drive that in the most appropriate way. So the problem with AMR and the problem with development is very broad. We need to tackle each of the points of challenge in it, and these acts and others go a long way to doing that. And in the absence of it, right, we're making no progress. We cannot allow where we are today to continue because we're just falling further and further behind the problem. And so again, the urgency is there. It's imperfect. There's no perfect plan. It doesn't do everything possible at once, but it's a huge step in the right direction and allows us to build off of it and to measure it over time.
It seems like a critical element. And maybe, Mike, I could go to you first. Again, continuing this theme of policy approaches to complement the pull incentives that PASTEUR would create. You're at the Centers for Disease Control and Prevention. We had a question too, and this has come up already, about what can we do in terms of reducing the use of antibiotics, which the participant noted are high relative in the U.S. Relative to some parts of the Western world. Maybe you could talk a little bit more about that, as well as the steps that CDC, I know, is involved with around surveillance of antimicrobial spread, and maybe how a pull incentive could be paired with supports for appropriate use of the priority antibiotics and maybe others as well.
Yeah, absolutely. And I think those, the additional, because I think that this is a fundamentally important point that's being made here, is that we need to develop new drugs, but new drugs alone are not going to solve the problem of antimicrobial resistance. And we can't develop our way out of the problem. So from the CDC perspective, we look at the need for development of new drugs, new antibiotics. We, along with diagnostics, new vaccines, everybody needs to remember the importance of a vaccine, because preventing an infection in the first place, even if it's a viral infection, often prevents the use of an antibiotic, because that means you're not going to the doctor, you're not getting inappropriately prescribed an antibiotic. But the other things that are also fundamentally important that we need to talk about are improving the use of our antibiotics, the ones that we have currently, and that's improving the use in human medicine, which is the focus of what we do at CDC, but it's also paying attention to the use of antibiotics wherever we're using them. There is, as we've talked about, use of antibiotics in agriculture, making sure our animals stay safe. And then there is use of antibiotics in the environment, which I don't think folks fully appreciate. There are antibiotics and antifungal agents that are used as pesticides, and the resistance to those pesticides that develops in the environment can lead to some human infections. We've seen this for things like Aspergillus fumigatus. And there are concerns that the growing spread of the use of antimicrobials as pesticides could make some of those issues worse. Surveillance, as you mentioned, is fundamentally important to this, because tracking the infections that are happening, whether they're happening in our country or in another part of the world, is fundamental to understanding what are the problems that we're seeing, where is the resistance happening, and what can we do next to address it. The other thing that I would also like to underline is the real importance of infection prevention. preventing an infection in the first place, whether it's in the hospital, in a nursing home, or in the community, is ultimately going to save the antibiotics we have now. It's also the best way to stay healthy and make sure that you or a family member is not ever in a place where you need an antibiotic that may not work. And we need to remember and redouble our efforts on infection prevention, because those infections that are prevented in the first place are the ones that we don't need an antibiotic for. And that prolongs the life of new antibiotics as well as old antibiotics.
Yeah, I appreciate your point that the more we pay attention to those prevention issues, the surveillance and containment issues, the less we're going to need to rely on new funding and new urgent development programs for these PASTEUR type priority antimicrobials. Can you comment also just maybe briefly on the challenge here of needing to get funding essentially set aside or committed ahead of time for products that take many years to develop? Obviously, making those numbers smaller would make this program easier through the kinds of steps that you've described, but any other suggestions for how to make such a program sustainable?
Yeah, I mean, I think it's the $11 billion question, so to speak, for this. I think it's one of those things that what I always like to say when asked about this is that we're going to pay now or we're going to pay later, right? But at some point we're going to pay. Because if we don't address this, then what we're going to see is that we're going to see increasing resistance, and we're going to see increasing costs of care, right? It's very expensive when we see these resistant infections, and the more resistant infections we see with an aging population, the more costly it's going to be for Centers for Medicare and Medicaid Services, for the average consumer, for everyone. And so we are going to pay as a society for these. And we're, in the future, if we're choosing to pay by doing nothing, we're also going to see more death, more morbidity, more challenges, and it's going to undermine our other care, as we talked about before. It's going to undermine cancer chemotherapy, lead to more complications there. It's going to complicate surgeries, all of the things that we've come to rely upon antibiotics for. And it's going to increase the cost of medicine, which is, quite frankly, not something that our country needs more of.
And Helen, I'd like to continue on the theme around antimicrobial stewardship, a critical complement to make PASTEUR effective if and when it's funded and implemented. You talked in a recent congressional hearing on antimicrobial resistance about the importance of stewardship programs and how they're challenged today. Boy, this seems like a tough year across the board in healthcare. Staffing and supply costs are up. A lot of the additional help that healthcare organizations received during the public health emergency is going away. Can you talk a little bit more about this? And are there any opportunities for relying on digital technologies, new diagnostics to kind of make the job easier for healthcare organizations?
Yeah, it's a great. There's a lot packed in there, Mark. But so stewardship works, right? We have evidence that stewardship programs work when they're run by well-trained people. And the fact is that we're in a real crisis in the infectious disease workforce, including stewardship. And we have states, many counties and many states who have no infectious disease practitioners, much less good stewards. So to your point, programs of telestewardship and networks-based stewardship are developing, and some of them are quite effective. You still need expertise to run those programs, and we still need to develop more in the way of a workforce. So we need, I believe, to incentivize that. And so the Infectious Disease Society of America has worked with leaders in Congress to develop things like loan forgiveness for people who go into these careers, and other ways to make careers, whether it be in public service like at CDC or being an antimicrobial steward, more attractive. But I think there's more to do there. The other thing just comes back to what Mike was talking about in terms of preparation and preparedness. The Presidential Advisory Committee just issued a report on preparing for the pandemic of AMR. And I would just commend that to folks. It has a lot about stewardship as part of that work and infection prevention. What we've seen sadly in the beginning of the post-COVID era is a reduction in our preparedness resources. Exactly what we don't need to see to be ready for this. So I know it's a hard sell, but it's really important, I think, for policymakers to hear that we know that being prepared works. It's a way to get better data and have the data we need and be able to pivot and act in times of emergency like the Pseudomonas eye drop outbreak. The reason that worked was because the CDC could do their job and liaise with the states and the local departments of public health to act. It's a very great story, you know, if you want to read a good story about how it worked.
Yeah.
But it worked because the infrastructure worked. And I worry with this disinvestment that we won't have the infrastructure to respond to the next one, which we know is coming.
And this may get it, just to follow up with you for one more minute. One of the questions that one of our participants raised was, in the event that PASTEUR is implemented, what are the safeguards or guardrails or associated incentives, so sticking with the incentives that could be put in place to help prevent off-label use of the product, to help make sure that it is contributing to maintaining and improving resilience against resistant organisms. I appreciate the point about just how critical public health infrastructure is to support this, but it seems like we also have some opportunities to build into healthcare through good use of diagnostic tests, decision support systems, and align financial incentives there, a better foundation for the effective use of these products.
Right. Well, so PASTEUR, just to address that first, PASTEUR does include very clear stewardship guidelines, including the necessity to report on how these antibiotics are used and antifungals are used. That's data that, believe it or not, in 2023 in America, we don't have readily at our fingertips, which we should. And so that having that data will allow experts at the CDC to really infer and conclude as to whether the drugs are being used effectively and to intervene when they're not. So that's very important. Diagnostics are a great tool, and we need more of them to help us know, A, that we're treating a bacterial or fungal infection, and B, that we're treating it with the right drug. And that is an area that really requires more development and execution. And again, back to how we pay for them. Diagnostic tests are very complicated in terms of payment. When most of our patients are treated under DRGs in the hospital, an expensive diagnostic test can be a hard sell to our hospital administrators to bring on board. And so thinking about that from a policy perspective and weaving that into legislation like this is very, very helpful as well.
Yeah, I think both from the standpoint of public health to Mike's comments and healthcare to yours, this notion of more effective testing and more targeted and appropriate treatment is something that we've got further work to do in conjunction with PASTEUR to build into our public health healthcare containment systems for this threat of antimicrobial resistance. Well, I can't believe it. We're already almost out of time. Henry, could I go to you quickly? I know you wanted to talk about workforce development. We had a couple of questions related to support for people who want to be effective stewards. I think Helen and Mike have helped touched on that, but maybe any final comments you'd like to add? And then if I can squeeze it in, one more question from our participants about a product developer. So there still are some out there who's working on a parenteral, instead of not just oral parenteral therapies, topical therapy for a resistant organism, including the one MRSA, one that we've talked about today. Is that fair ground for PASTEUR potentially? And then maybe any final comments you have.
Yeah, thanks, Mark. I think it absolutely should be, right? I think it was mentioned the best way to manage infections is to prevent them. So if we can find ways to decolonize mupirocin back in the day, although the effectiveness has declined, to reduce the propensity to get an infection and for infections to spread, that's a huge societal benefit and a lot of value. We absolutely should incentivize that type of innovation as well. If we think about vaccines, right, the impact they've had for both bacterial and viral infections. But I want to touch on one thing, right? So we mentioned investment, and this goes to people it goes to the workforce, it goes to the technology. We were incredibly fortunate in COVID to, within a year, have a vaccine based on an entirely new modality that was only there because we invested in that technology for previous decades, hundreds of millions of dollars. And if we did not invest in that foundational work, we'd probably still, be in a much different place than where we are. So the investment is critical, right? We need to invest in people, we need to invest in technology and innovation, and we need to enable scientists, entrepreneurs, and clinicians to do what they do best, to stay in front of this and to mitigate the impact that we have and to know where we're heading.
Well, thanks very much for that final comment. I want to thank all of our participants who attended today for some great questions. We got to some, but not all. We'll try to follow up on some of the rest. And a special thanks to our panelists as well as our staff for making this a really information-packed hour on a topic that unfortunately is getting more and more timely and important to address from a global public health standpoint. We really appreciate your being with us today. We are going to try to build on the ideas discussed here, including placing PASTEUR in a broader context. So look for further webinars and activities from Duke Margolis in collaboration with experts like those you've heard from today in the future. But for right now, thanks again for joining us, and take care for the rest of the day.